Thanks everybody for coming. So today we're going to have our UCSD Prepare Institute seminar given by Dr. Nizet. And I'm going to do a quick introduction and let him get started. But he's a distinguished professor and vice chair of basic research in the Department of Pediatrics and chief in the division of host microbe systems and therapeutics, and distinguished professor also in the School of Pharmacy and Pharmaceutical Sciences at SCAGS. And he is graduate of Reed College and received his medical training at Stanford and completed his residency and chief residency at PEDS at Harvard and then Children's Hospital in Boston, and then a fellowship in PEDS ID at University of Washington there in Seattle. And he's the faculty lead for the UCSD Collaborative to Halt Antibiotic-Resistant Microbes, CHARM. So please check that out as well. They have a great seminar series and is a multidisciplinary research and educational program that started back right before the pandemic in 2019. He's authored over 500 peer-reviewed publications and has collaborated with all of us and is a friend and colleague for many, and also several biotech interests in developing new antibiotics and immune-based therapies for drug-resistant pathogens. And he has a whole list of things that he has done and been awarded, and members of various societies, including American Society for Clinical Investigation, American Academy of Microbiology, Advancement of Science, etc. And I wanted to ask him, he could start off his talk with just a little bit. These seem sometimes overwhelming, all these different societies that we have in academic medicine, about which ones of these might really be useful for people to think about as they progress in their academic career. What kind of advice would you give, Victor, for somebody coming up? And then you can take it away in your talk.
Okay, that's a good question. Yeah, I think as people are beginning to engage with professional organizations and to engage in academic science and research, you'll want to be able to share your research and learn from others in the field. I've been kind of a fan of joining the big societies and attending the small meetings, I guess I would say. For me, the big societies, especially as web-based tools and interactive platforms have developed, there's a lot of newsletters, forums, podcasts, anything from a chat room to user forums that people can interact with, and sub areas of interest develop in those. So for me, the American Society of Microbiology, scientifically, the Infectious Disease Society of America, on the clinical perspective, we're good. Both of these society memberships also come with the opportunity to receive the journal publications. But for little meetings, sometimes I found the meetings of those societies a little bit overwhelming early on. They often have 10, 20,000 people attending in a big convention center, and by the time your poster presentation comes up, there's so many competing sessions, and people are running into people they know they may never get to your poster. So although you might see a lot of interesting things, I think the personal networking is a lot less than if you went to a Gordon conference, a Keystone Symposium, something on your specific immune cell or organism, and where there's one set of speakers and everybody eats meals together, and the posters are up for multiple sessions. There's a lot better chance for you to gain in your networking. But hit me up if you have more questions on that specific to your own interest. So with that, thanks for the introduction, Davey, and the invitation, Steele, to come and present a little bit about some things that we're up to under an umbrella title of collaborating with the innate immune system to treat some of these drug-resistant superbugs. So our lab works at the interface of bacterial pathogens and the innate immune system. I focused principally on common bacteria that colonize all of us, but also can produce significant disease, staph, strep, E. coli, for example. And um, the reason that we don't get disease with these pathogens the majority of the time is because we have a big, formidable innate immune system that contains physical and cellular and molecular barriers that restrict the spread of the pathogens. But occasionally, we do see clinical disease with a more deep-seated infection, which by definition means that the innate immune system has dropped the ball. The pathogen has entered privileged spaces. And our lab has been interested in understanding what allows certain pathogens to do that. We call those virulence mechanisms, and why the innate immune system works so well the majority of the time, but breaks down some of the time. So I'll start this one off with a little quiz from a clinical micro perspective, asking if anybody knows who these notable clinical microbiologists are. I can't really see you right now, but I'll give you a clue that the man on the left was the chairman of clinical microbiology at Harvard in the 30s to the early 50s. And the woman at the right was a graduate of Simmons College right across the street, Longwood Avenue, who, as a postbac, came to work in his lab. She ultimately became the first African-American female veterinarian in America at UPenn. But in her postbac work, Jane Hinton, while working with Howard Mueller, had a very simple proposition, which was to develop a media which could propagate the growth of a wide variety of bacteria of clinical interest, so that when you're working in the microlab and you have that precious drop or two of spinal fluid and you want to make sure you get the bacteria for clinical identification and workup, that we could grow the majority of the bacteria successfully and quickly. And they came across this media that came to be known as Mueller-Hinton broth, and was very good at growing the fastidious gonococci and meningococci. And people tuned it up later to even help with growth of Pseudomonas. And this became very popular, spread around the world, and became the predominant media for isolation of common bacteria from clinical specimens. But at the same time, we were starting to see antibiotics become drugs of clinical utility. And as new antibiotics were developed, it became convenient to test their potency in the same media that was being used for the bacterial isolation. And so right now, and all the way to this day, throughout the US and Europe, Australasia, everywhere in the world, standard antimicrobial susceptibility testing is performed on Mueller-Hinton broth for the common organisms, and that can be on agar or in liquid media. But the problem is that we are trying to treat infections in vulnerable patients, like as a pediatric ID doc myself, might be a patient in the NICU or a patient in the ICU or the cancer ward. And we're trying to predict the activity of the antibiotic in the patient's body. And the body is made up of tissues and fluid and blood and serum. And that's not Mueller-Hinton broth. There's no seaweed-based agar there. And it's not beef heart infusion and casein at arbitrary concentrations that promote bacterial growth. And I think all scientists recognize that when you do experiments in the lab and you change the media or the environmental conditions, you can get different results. And that's one thing that we'll illustrate here. Moreover, before the patient has ever been seen by the doctor, their infection is already being treated by dozens of antibiotic factors. So your body makes natural peptides and proteases, oxidants that have antimicrobial properties They could be studied in essence in the same way that an antibiotic does, but the whole antibiotic testing paradigm in the clinical lab on the seaweed auger does not incorporate any aspect of innate immunity. So any potential antagonisms or synergies are missed. An example of the kind of antimicrobial peptides we study are these cathelicidins. We've been working with Richard Gallo, the UCSD chief of chair of the Department of Dermatology, for more than 2 decades. These are small peptides like the human LL37 or the mouse paralog cramp that are cationic in nature, which attracts them to the gram-negative and gram-positive bacterial surface, which is anionic or negatively charged, and disrupts the bacterial target membrane. They have broad spectrum antimicrobial activity against multiple bacteria, even many parasites and enveloped viruses. And they're produced by our immune cells, like neutrophils and macrophages and mast cells, but also epithelial cells. A neutrophil is jam-packed with cathelicidin. And you can see that they're also inducible, that at baseline, for example, your skin does not make much cathelicidin, but if you injure it, the expression is strongly upregulated. Or in this case, if we give the mouse a strep infection, a lot of cathelicidin is produced. So behaves like a molecule of the innate immune system and has the capacity to kill microbes. And very early on, we found that if you created a mouse that was deleted for the cationic antimicrobial peptide, cramp, the human version being LL37, that the mouse is very immunocompromised. A low dose infection that it would normally clear over the course of the week just keeps getting larger and larger and larger, and the bacterial counts keep getting higher and higher and higher. So it's a critical element of your innate immune system. But these antimicrobial peptides, as well as the action of your white blood cells, the complement system, toll receptor signaling, all sorts of other antimicrobial properties, the whole antibiotic testing paradigm is conducted completely oblivious to this component. And I think there's significant consequences of that. So I'll divide the talk into 2 parts. The first one is about reconsideration. Given what I just told you, are we potentially underestimating the therapeutic potential of certain FDA-approved antibiotics by evaluating them in a way that doesn't take into account the host innate immune system and is done in an artificial media, not resembling the body very much? And the second part will be a very hot topic in medicine now, drug repurposing. If you really redefine infectious diseases as not just what a chemical could do to a bacteria in a test tube, but what a chemical could do to the host pathogen interaction, somehow benefiting the host, then it's possible that all sorts of drugs which work on host cells might improve their resiliency or their behavior in a way that could have them perform better against bacteria. So I'll give some examples of that. So one example that we had been playing with in the laboratory, and many others as well, was that certain antibiotics seem to have a reciprocal relationship to one another, such that increased susceptibility to one is associated with increased resistance to the other, and vice versa. This is kind of a push me, pull you, or seesaw effect, we say. One that we were studying with relationship to resistant staph infections was daptomycin. Daptomycin, the peptide antibiotic, when you treat patients with daptomycin, eventually they might become non-susceptible or resistant to the daptomycin. But what we observed is those daptomycin non-susceptible isolates that were emerging resensitized themselves to a variety of beta-lactam antibiotics. And a good example of this that George Tsoukalos, who many of you know, and has been a long-term collaborator, has worked with me on is illustrated by this case study. One of these nightmare type of patients with very, very difficult staph infection of the heart valve and being treated with vancomycin and daptomycin because it's MRSA, 21 days of positive blood cultures, even adding aminoglycosides. The bacteria is becoming more resistant to the drugs by fourfold on therapy. But remember, daptomycin resistance might have been associated with a resensitization in the laboratory to beta-lactam antibiotics. So we reinstituted a drug that's not supposed to work, nafcillin. You would never use nafcillin for MRSA, which are by name and in vitro testing, highly resistant to beta-lactam antibiotics. But in fact, this patient's bacteremia was resolved and he had a durable cure. And we saw this over and over and over again. Patients that were experiencing MRSA bacteremia that were failing on daptomycin, their strains were becoming more resistant to daptomycin, and then we reinstituted nafcillin, or in this one case, oxacillin, and achieved a clinical cure. So what's going on here? Well, here we see the daptomycin antibiotic labeled with a fluorescent yellow, and now we're either exposing it to nafcillin or not. And we see that exposing it to nafcillin, which has no direct bactericidal activity, did, however, affect the bacterium, change the bacterium so that its cell wall was now being attacked more efficiently by the daptomycin antibiotic. And daptomycin is effectively a cationic antibiotic because it binds calcium 2 plus in vivo and uses that acquired positive charge to interact with the gram-negative bacterial membrane. And this to us was reminiscent of the positive charge of the endogenous antimicrobial peptides like the human cathelicidin that we were talking about in our collaborative research with the Gallo Lab. So we wondered if all these patients getting so dramatically better by reintroducing a beta-lactam that wasn't supposed to work might be not only because it synergizes with the daptomycin, but even more critically, because maybe it's synergizing with the cationic peptides of your innate immune system. And that's indeed what we found. Adding nafcillin markedly sensitized even vancomycin intermediate VISA strains of staph to killing by our own endogenous antimicrobial peptides. Even a little homeopathic dose of 1.5 of nafcillin had a marked effect. And this was something that was shared with multiple other beta-lactam antibiotics, but what was it not shared with? The drugs that we were treating the patients with. You treat MRSA patients with daptomycin and vancomycin and linezolid, and those do not show synergy with the cationic antimicrobial peptides. In fact, even vancomycin-resistant strains were being sensitized. If you sensitize to the cationic antimicrobial peptide, you might imagine you could sensitize to killing by the cells that make the antimicrobial peptide, like neutrophils and monocytes that are circulating in your blood, or keratinocytes. And here you see that same kind of phenomenon where now we're labeling the human antimicrobial peptide with a red fluorescent color and exposing the MRSA to the nafcillin allows the endogenous antimicrobial peptide to attack the bacteria. And here we see a little bit of a clinical reduction in the mouse model treated with MRSA infection with nafcillin alone, which is not supposed to work, of course, but this we attribute to synergy with endogenous peptides, which the immune system is making. And we've gone on to show, in maybe more than 24 papers now, all sorts of other examples of gram-positive bacteria being resensitized to beta-lactam antibiotics, even enterococcus, and pneumococcal strains that are ceftriaxone resistant. And now we have a beta-lactam antibiotic, ceftaroline, which itself has some direct MRSA activity. It also shares this synergy with the innate immune system and synergy with daptomycin, and is now recommended among other choices as a potential salvage treatment for MRSA. We might argue, why do you allow them to work their way into the state where they need salvage treatment and not consider this type of synergy up front? This work has led us into the realm of gram-negative infections as well. Many of you recognize that carbapenem-resistant Enterobacteriaceae, Pseudomonas that are multi-drug resistant, Acinetobacter, a #1 threat identified by the CDC and the World Health Organization, are often pan-resistant. Here's some isolates from our own hospitals, where you see the organisms are resistant to essentially everything on the antibiogram, even the carbapenem antibiotics like meropenem. And deep-seated infections with these type of organisms obviously have very high mortality risk. What are we treating these patients with? Often a last-ditch drug that has activity against many strains, although resistance is increasing, is the colistin. Colistin, and this is a theme recurring, in fact, is a cationic peptide antibiotic because it has these diaminobutyric acid charges. It just comes from a bacteria. It's a little bit difficult to work with, of course, because there's renal toxicity, and many of these patients are very sick in the ICUs, and renal function is a concern. So in this case, we went back and looked at the antibiogram and tried to think about things that weren't being tried. And one of the things that we recognized that there's a very commonly prescribed antibiotic that is never recommended for gram-negative bacteria, even though, and the reason is that it has no activity in the standard MIC testing, and that is azithromycin. Azithromycin of the Z-Pak, very convenient, commonly prescribed for self-limited upper respiratory tract infections, for example. But if you had a Acinetobacter, a CRE, or a multi-resistant Pseudomonas, not only would they not report the testing, they may not even conduct the testing. In fact, I don't see it reported as an option in any hospitals in America, certainly. But Leo Lin, who was then MD PhD student in the lab, is now an assistant professor and director of one of the Arup labs in the University of Utah, came at this question with the recognition that the patient is not made out of the Mueller-Hinton broth, and thought, what if we just did the testing in a media that was more similar to the media that are the physiologic conditions of the body? And the idea here was to use tissue culture media, which propagates the healthy growth of human cells. And if you look at the MIC of the bacteria in a tissue culture media, RPMI, compared to the Mueller-Hinton broth, you see that the MIC is dramatically lower. And in fact, what you see here is that azithromycin, even at tiny little concentrations in, in tissue culture media, in which the bacteria grows just fine, completely kills all the bacteria so that there's no detectable bacteria at 24 hours, whereas there's essentially no effect of the azithromycin under the standard testing conditions. Here you see azithromycin in tissue culture media causing the morphological changes that we call the toroid nucleus, which is one of the classic features of protein synthesis inhibition. This does not occur in the standard testing media on which we're excluding this drug as an option. Here is 1/8 the concentration of the MIC of azithromycin exposure to Pseudomonas, and it changes the Pseudomonas from a rod into a coccus. So there's obviously an effect going on here. This represents a weakening of the cell wall. That stronger cell wall is required for the rigidity that allows an elongated shape, and it reverts to a sphere, the lowest kind of surface tension state. Beyond the increased activity, there was also marked synergy of the azithromycin with the endogenous antimicrobial peptides. So you see here multi-log bactericidal synergy between LL37 and azithromycin against these multi-drug resistant strains of Klebsiella and Acinetobacter. And here we've labeled the azithromycin fluorescently green and added a little bit of LL37. And you can see that the azithromycin gets inside the Acinetobacter, where of course it needs to go as a ribosomally active protein synthesis inhibitor. But here's what we're doing in the clinical lab. The azithromycin doesn't get inside the cell, so of course it doesn't work. But at every site of infection, there's going to be this amount of LL37 and other cationic peptides facilitating entry likely. Also, we see the same effect with colistin, suggesting they may be a powerful synergistic or colistin dose sparing option here. Well, your body is making the antimicrobial peptides, so we should be able to treat mice with multi-drug resistant, essentially pan-resistant, gram-negative superbugs with one of these most common antibiotics that you wouldn't hesitate to give to a kid for an ear infection, or one of your patients for sinusitis or bronchitis. And here we see that one dose of azithromycin led to a 2 to 3 log reduction in the amount of multi-drug resistant Acinetobacter in the lung, associated with much less inflammation, damage. You can see here how much better your lung looks with a little bit of azithro. And at a dose that would kill 80% of the mice, 2 doses of azithromycin saved the vast majority of them. So a drug that is readily available, is completely discounted, never even tested or reported, but obviously has activity under physiologic conditions. And Monica in the lab has gone on to show that this works well for Klebsiella pneumoniae, Pseudomonas, multi-drug resistant Stenotrophomonas. We've also published a paper on Achromobacter. All these unrecognized activities. And there's probably just the tip of the iceberg if you start re-examining antibiotics in this context. Julia Ulloa, now an assistant professor at UC Irvine, PEDS ID doctor, showed that avibactam, a non-beta-lactam beta-lactamase inhibitor that's part of Avicaz, never really considered its own antibiotic, has this kind of dramatic synergy with the antimicrobial peptides, leading to very effective killing, even of NDM1 multi-drug resistant carbapenem-resistant Klebsiella. And here you see the attack of the LL37 on the bacteria after exposure to the avibactam, complete killing of the bacteria in serum, sensitization to neutrophil killing, an in vivo therapeutic effect, and again, changing rods into cocci. So that finishes the first part of the talk. Just to get you to reconsider, we now have come close to initiating in India a clinical trial of azithromycin for treatment of MDR gram-negative infections, because they have a lot even coming from the community. It'll just be added on to standard of care, and we'll see if it makes a difference. As for treating the gram-positive bacteria, George Sakoulas led a multi-center study of combination of ceftaroline and daptomycin versus standard of care, which was mostly Vanco, and had to stop the study early because no patients died in the dual treatment group. And we had lost the equipoise, and it didn't seem ethical to continue, and we'll have to design a better study to move further. Also decide whether ceftaroline alone is sufficient to achieve this effect. So I often come up with George Bernard Shaw in Google searches because I studied GBS bacteria. So that led me a little more curious about his writings. He has this interesting play called The Doctor's Dilemma, and I found in there this cool saying by the character Dr. Bloomington Bonington: there is at bottom only one genuine scientific treatment for all diseases, and that is to stimulate the phagocytes. I'm kind of buying into this. Here's the cover of Science from back in 2004. Friends in Berlin, Germany, Artur Schitzlinski and Volker Brinkmann described what is known as neutrophil extracellular traps, which has become a very big topic in innate immunity. This is basically a specialized cell death process that neutrophils undergo in the tissues, where they release their nuclear DNA to create a sticky web in which extracellular bacteria are trapped and killed by the histones and the cationic peptides like cathelicidin that are found in the nets. Here's a picture from our lab of a neutrophil netting and capturing a bunch of staph. It's basically what pus is. No one really wanted to study pus because it's pretty disgusting, but it's also useful if you think about it as kind of a quicksand in the tissues, trapping the bacteria from spreading further. So a number of years ago, clinicians were pointing out to me that patients who are on statins, one of the most widely prescribed drug classes and a cornerstone of cholesterol lowering therapy, because they lower your bad cholesterol and raise your good cholesterol, that patients who happen to be on statins were reported to have reduced mortality in bacteria, sepsis, and pneumonia clinical studies. And there was a hypothesis that statins, which are known to have some anti-inflammatory activities, might be toning down the sepsis. But that didn't really make much sense to me, because in general, if you a priori give a patient immunosuppressive or anti-inflammatory therapies, they become more susceptible to infection. So I wondered if it could be, working on the host pathogen interaction, which was easy enough to study. On Chow, who was then an MD PhD student, explored this in collaboration with Chris Glass. He found that if you treated white blood cells, human or murine, neutrophils or macrophages, with statins for a few hours and then exposed them to bacteria, they killed the bacteria better. And it was not just staph, as you see up top, but many species of gram-positive and gram-negative bacteria. And when we looked into the mechanism, consistent with the prior literature, the oxidative burst and the phagocytosis by the bacteria by the statin-treated phagocytes was actually less, which made us think that it must be an extracellular mechanism in killing. And in fact, what we found is that the statin pre-treated leukocytes, when they were exposed to bacteria, they made nets more efficiently and released the antimicrobial peptides into the nets. And that was responsible for the killing. And many different statins achieve this. In fact, if we used RNA inhibition to knock out HMG-CoA reductase, the pharmacological target of statins, we had the same effect. And then we started treating mice with statins, and we found that the mice made their immune cells, when you purified them, made more nets. They killed bacteria better. And if we treated the mice with statins and then challenged them in vivo with staph pneumonia, they did a better job at clearing the staph in association with increased deployment of nets in the tissue. So interesting, a drug that so many tens of millions of Americans are taking has a big effect on the behavior of their immune cells when they see bacteria. In this case, it seems beneficial. We found another example of this in tamoxifen, a cornerstone, of course, of breast cancer therapy. It also stimulated nets and bacterial killing. And this was through, interestingly, a estrogen receptor independent mechanism with an off-target effect we determined on glucosylceramide synthase to increase ceramide levels in the cell, which are known to stimulate a PKZ zeta dependent mechanism of nets. And tamoxifen also had a beneficial effect in rescuing a few mice from a lethal Staph aureus infection model and reducing bacterial counts. But I'm leading up with that work on phagocytic cells, which is ongoing, to go to something that maybe a lot of people would be less familiar with, and that is to ask what host immune cell in the blood is the most important for combating Staph aureus infection, one of the most common causes, if not the most common cause of bacteremia in most clinical cohorts in most countries around the world. And the surprising answer is that it's not any particular type of leukocyte, but rather the platelet. Well known for its role in clotting, less well understood for its roles in immunity, including its capacity to exert antibacterial activity. So in this clinical cohort of patients, the same ones where we're trying different combinations of beta-lactam antibiotics in synergy or not with daptomycin, we asked what correlates in their CBC linked to whether the patient ultimately survived or died. And the one correlation we saw was that thrombocytopenia, or a reduced platelet count, was associated with death. Now, that could be a chicken or the egg issue, but it was interesting that we found when we isolated blood from healthy individuals that platelets were able to kill Staph aureus. They don't kill pneumococcus, group A strep, group B strep, but they kill Staph aureus, and they kill Staph aureus better than neutrophils kill Staph aureus, which I thought was a pretty interesting phenomenon. So platelets have granules that contain a lot of their, bioactive factors that contribute to endothelial activation and clotting, but they also contain within them antimicrobial peptides, including the cathelicidin I described before, but also other factors like defensins and thrombocytins. And we think that there's basically a mano-a-mano battle going on in the blood between staph and platelets. The platelets want to kill the staph, and the staph wants to kill or eliminate the platelets. And we know that because when we infect the mouse with staph, it drives the platelet count down rapidly. This is 4 hours later. And if we come in and give a mouse experimental thrombocytopenia, let's say with an antiplatelet antibody as shown here, the mice are more susceptible to staph infection. You see significantly higher blood counts of staph 4 hours later, and better killing activity of their blood against staph ex vivo. So it seems like in general, our platelet count holds out, and this antibacterial activity is available to help clear the staph infection, but occasionally it collapses, and those patients become very susceptible to a bad outcome. So what is driving the platelet count down in staph infection? Well, it's a membrane active toxin known as the alpha toxin, which is expressed by the vast majority of staph strains. In our clinical cohort, we found that thrombocytopenia was more common in patients that had high alpha toxin producing strains. And if we made a mutant bacteria that was lacking the alpha toxin, it did not cause experimental thrombocytopenia, and it was more easily cleared by the mouse blood and in human platelets. So we're interested in drug repurposing, as we showed with the statin and tamoxifen studies. That led to a question, is this an opportunity for drug repurposing? There's quite a few FDA-approved meds that target platelets. We, of course, give that to people who've had a heart attack or stroke, including aspirin or more sophisticated antiplatelet drugs that could reduce the risk of further thrombosis and cardiovascular events. And what we found is when we did the platelet killing assay and added these different antiplatelet drugs, there was one class of drugs known as the P2Y12 inhibitors, clopidogrel, Plavix, or ticagrelor, Brilinta are examples of this, where we reduced the toxin-mediated injury to the platelets and helped the platelets kill the staph bacteria. Here at a very high dose of staph, those are the circles here, the staph bacteria, they basically vaporize the platelets. But if you do this in the setting of ticagrelor, the disc-shaped platelets are alive. And this is a dose-dependent pharmacological protection. And if you treat animals with Brilinta at human equivalent doses, we see that the degree of thrombocytopenia that is elicited by the staph infection is less, and the bacteria are more easily cleared from the mouse blood and disseminate less to the different mouse organs. In fact, there is a protection against mortality in the lethal challenge model, even in the absence of antibiotic therapy. And this is a drug that, many millions of Americans take safely as a chronic therapeutic. Another quiz question for a live audience would have been, how long does a platelet last in the circulation? Red blood cells, of course, last about 3 months. The answer for a platelet is a little longer than a week, maybe 9 days. And what controls platelet lifespan? Well, it's kind of interesting. It's a glycobiology answer, the kind of stuff that Ajit Varki here and Jamie Marth, who's at the Burnham Institute, study. Platelets have a bunch of glycoproteins on their surface, and the glycoproteins tend to exhibit a terminal sugar known as Nu5AC or sialic acid. And over time, the sialic acid is degraded or enzymatically cleaved by exogenous or endogenous sialidases. Even the platelet has its own sialidases. When that happens, the underlying galactose is present, and it is visible to a receptor, the most abundant protein on your hepatocytes, called the Ashwell receptor. And platelets are eliminated from the circulation, and of course, they're replenished by the marrow. So platelet ages, loses its sialic acid, becomes bald, and is removed by the liver. Well, what we found is that although Staph aureus doesn't have a neuraminidase or a sialidase, it induces the platelet sialidase, and the platelet makes itself bald. And this is dependent on toxicity from the alpha toxin in a dose-dependent manner. And this toxicity is what's blocked by the ticagrelor. And interestingly, if you eliminate the Ashwell receptor that is required for pulling the bald platelets out of the blood, the platelet count never decreases, even in the setting of staph infection. And these mice are completely resistant to staph infection. Now, it'd be hard to eliminate the most abundant protein on the liver from a patient acutely in the ICU, but one thing that we can do is maybe try to prevent the desialylation of the platelets. And as an infectious disease audience knows, we use neuraminidase inhibitors or sialidase inhibitors in medicine in the context of flu infection, because flu uses its neuraminidase to exit the cell and spread from cell to cell. And if you block that, like with oseltamivir, Tamiflu, which is not completely specific for the viral neuraminidase, but also acts on host neuraminidases, we found that same effect of reducing the amount of desialylation, stabilizing the platelet count, and having a therapeutic effect in vivo. So basically, we discovered that the most important thing in your blood for defending against staph is platelets. The staph is trying to take out the platelet is trying to take out the staph. This is dependent on an alpha toxin, which causes the platelet to desialylate itself and get eliminated through the liver. But now that we recognize this, 2 different FDA-approved, commonly prescribed drugs, ticagrelor and oseltamivir, could conceptually be therapeutically repurposed to improve outcomes in infection. And we published in CID a study looking at VA cohort of clopidogrel, another P2Y12 inhibitor, and saw potentially a therapeutic benefit. We've published some case reports, and hopefully somebody will do a trial to see if it has an added benefit. So I'm going to wrap up with one last story in the last 5 minutes of sepsis. This is a complex disease, of course, a leading cause of global mortality, 19% of global mortality, according to a Lancet study. Every hour of delayed therapy boosts mortality. Many different organisms, even polymicrobial infections, can cause it. A lot of complex patients, and there have been over 400 different host factors, cytokines and cellular factors and endothelial factors and platelet factors that have contribute to sepsis in one way or another. And more than 100 clinical trials, but none of the drugs have worked. So there is no FDA-approved drug for sepsis. And we believe that these failures reflect the fact that you can't simply target a single factor and solve such a complex disease. And our approach, working with Liangfang Zhang here at UCSD, has been to use a biomimicry or a wolf in sheep's clothing approach, where we're basically co-opting our own cell membranes and converting them into a biomimetic nanotherapeutic. What do we mean by this? Well, imagine if you took red blood cells, like O-negative red blood cells, and purified their membranes and used them to coat tiny little nanoparticles in a manner that they were the nanoparticle, now at 1/50,000th scale of the parent cell, exhibits the exact same membrane with the same lipid bilayer and the same surface proteins and receptors as the parent cell. So a lot of bacteria make toxins, and we've talked about the alpha toxin of Staph aureus and how important it is at driving disease pathogenesis. It is also known as the alpha hemolysin because one of the cells it can target is red cells. Well, we made nanoparticles from red cell membranes and used them to coat use the red cells to coat the nanoparticles to create a nanodrug, which we found markedly inhibits lysis by alpha toxin, provides fantastic protection in a staph alpha toxin model, as well as protection against mortality and reduction of bacterial counts in a MRSA pneumonia model. And in fact, this drug that we are describing here just received last week FDA approval to enter phase 1 clinical trials as a therapeutic for MRSA hospital-associated pneumonia. Here's an example of the same red cell nanoparticle being used to combat Staph aureus disease, the strep pyogenes disease, the beta hemolytic group A strep. Produces pore-forming streptolysins, which are captured and neutralized by the red cell nanosponge. And here's a therapeutic effect in the animal model. But I mentioned sepsis. What about sepsis? Our idea with sepsis is to go into a next generation nanotherapeutic, where instead of using the red cell membrane, we are using the macrophage cell membrane, but making 1/50,000th scale macrophage nanosponges. The idea is that the macrophage is a central orchestrator of the inflammation in sepsis, and the macrophage nanosponge, in addition to being able to absorb toxins that would otherwise damage your own macrophages, would express toll receptors to bind LPS and cytokine receptors to calm down the cytokine storm. And this tripartite mechanism of action, absorbing bacterial toxins, absorbing bacterial pro-inflammatory factors, and mitigating the cytokine storm, could be used as an adjunctive therapy for sepsis that would kind of be agnostic to the particular pathogen and AMR profile. And what we indeed have found is that macrophage nanosponges are effective at sequestering LPS, sequestering key pro-inflammatory cytokines like TNF, IL-6, and interferon gamma, and protective in a murine lethal LPS challenge, whereas red cell nanosponges were not. Here you can see the kinetics of suppressing the inflammatory cytokine cascade. And we've seen a therapeutic effect in septic models of E. coli, which we've now extended to MRSA. And Angela Meyer, associate professor of anesthesiology, who many of you might know, has extended these observations now as well to gram-negative pneumonia with Pseudomonas, and we're going to be exploring that as a therapeutic. And we got a big grant through the CARB-X initiative to develop this nanotherapeutic for a sepsis indication, and hopefully we can also look at it in lung infection. SARS is always on everybody's mind, the macrophage also has the ACE2 receptor for the SARS virus, and is able to neutralize the virus and could also have benefit in viral pneumonia. So to wrap up, we do our antibiotic testing on seaweed to declare sensitivity or resistance, but I think maybe a more useful approach would be to look at our patients. They're getting antibiotics that are supposed to work, and they're either on their way to recovery or they're getting sicker and sicker. And that's really the definition of sensitivity or resistance, not what was done in an artificial media in a laboratory. And if we don't take this more holistic approach, I think we're shooting ourselves in the foot. We became complacent because of the effectiveness of antibiotics as a treatment. Cancer doctors never became complacent because there were so many difficult cancers for which they needed better outcomes. They embraced immunotherapy, CAR T cells, PD-1 inhibitors, dramatically improved outcomes in a lot of cases. And I think we could do just the same for infectious disease. Remember, it's a host pathogen interaction. Look at all these potential mechanisms for improving our outcomes and move beyond simply classical antibiotics for treatment. So I'll stop there. It was a big survey course. Want to thank lab members past and present, including a lot of faculty who who are still here at UC San Diego, like Aaron and Monica within the ID division, Amanda Lewis in OBGYN, George Liu, the chief of PEDS ID, and David Gonzalez, who has a fantastic lab studying host pathogen interactions in pharmacology in the pharmacy school. And I'd be happy to answer any questions.
Yeah, we have a few minutes. If anyone has any questions for Dr. Nizet, please feel free to post them.
Hi there, this is Anna.
Hi, Anna.
Yeah, thanks for a great talk, super inspiring. I wanted to hear what your thought was, because I've been working with the neurosurgeon up at UW. She's doing thrombectomies of stroke patients, and we're sequencing the microbiomes of these clots she's pulling out. And of course, we found Staph aureus that are colonizing some patients' clots, but other patients have clots that are colonized or at least associated with the oral microbiome, such as different Streptococcus species. And I was wondering if that is something that you know something about the correlation. Do you see like the sort of the same arms race between clotting and the strep species, or?
Yeah, no, I think that that's very important. I think the oral microbiome and dental caries and gingivitis are a disease. What disease does essentially everybody have? Mm-hmm. And almost everybody gets surgery for, and not as much research is done as should be. That would be the example, because there's significant correlations between those and a lot of evidence of systemic inflammation and mm-hmm. higher risk of cardiovascular disease, et cetera. Mm-hmm. I've also thought that this would be one of the greatest areas and most accessible areas because of the multi-species and, undoubtedly, very complex virulence factor regulation for these types of broad spectrum therapies that mm-hmm. we're talking about. Could you come in a way that would physically sequester these factors and tone down the chronic inflammation in the manner of a, dental rinse or mm-hmm. Toothpaste or something that could be administered, because that would be, very benign, could be administered chronically, and I think is something definitely explored. But a lot of these factors are absorbed. There's worry that they enter the central nervous system and contribute to Alzheimer's plaques, but certainly, the organisms themselves and the heightened inflammatory tone and procoagulant tone contribute to diseases like atherosclerosis and infectious risk like endocarditis. So yeah, I think
all of the patients that she has, definitely, because she has x-rays to like compare in parallel, all of them have had some oral surgery, gum inflammation, loss of teeth, surgery. So it's quite interesting that.
No, I'd like to maybe follow up on that, because I think it's really interesting to have the clinical tie. Of course, we don't have a dental school here, but that's, will be great to bring it together. Yeah,
let's talk about that. Thanks.
All right, it's 4:02. Does anyone else have a question for Victor?
You guys know how to reach me, of course. Just right around the corner. Our lab's in BRF2. We collaborate with everybody. And really, especially interested in, young trainees or even established faculty at critical junctures, trying to see how we might be able to help, get involved in this kind of interdisciplinary research that'll make infectious disease outcomes better.
Well, Victor, thank you so much for being willing to present today, and of course, giving an amazing talk. It's been just great. So I just wanted to remind everyone, this seminar series is ongoing. Our next one will be on Tuesday, June 21st, from 2 to 3 p.m. And we'll have Dr. Ravi Goyal speaking about mathematical modeling as relates to various subjects, including the Return to Learn program, COVID vaccine hesitation, and then how we evaluate vaccine uptake, or how we best model for clinical trials for vaccine effectiveness. So with that, I'll say thank you to everyone for making the time today. We hope to see you next month. And again, Dr. Nizet, it's been a pleasure. Thank you so much.
Okay. Bye all.
Bye.
Take care.